We have two presenters joining us here this morning. Peter Fitzgerald is the Executive Vice President for Policy and Strategy at the National PACE Association, where he leads efforts to increase older adults' access to PACE's community-based, fully integrated care model. Regina Sayers has been Executive Director of the Appalachian Agency for Senior Citizens since 2010. AASC operates more than 30 programs, including All Care PACE, with a $14.3 million budget. And with that, I would like to turn the floor over to our presenters here, Peter and Regina. Welcome.
Thank you.
Thank you, Steve. So I'm going to kick this off. This is Peter Fitzgerald. I'd like to thank all of you for joining me this morning, I think for most of you, and this afternoon for some of you, depending on where you're sitting. And I always like to start when I talk about PACE with the origin of the program, because I think it's very telling as to the intent and the design of the care model when you go back to how it started. And what you see here on this first slide is a picture of Dr. G, who was a dentist in the Chinese American community in San Francisco, and Marie Louise Ansek, who is a social worker in the same area. And they were approached by families in that community asking to develop an alternative to putting their elders in a nursing home, which at that point, the only available nursing home in the San Francisco area was a considerable number of miles outside of the city, very inaccessible, and also an institutional setting into which the families did not want to place their elders. The first thing that they could think of to do was to try and build a different nursing home closer to the community in which they lived. But even then, in San Francisco, it was the property was scarce, and it was difficult financially to put together the funding to actually construct such a facility. So really, out of necessity, they came up with the idea of providing another space, another form of care for elders who needed really a nursing home level of care, but weren't able and didn't want to go off to the nursing home in the institutional setting outside of the city. And the first thing that they thought to do was to create an adult day care space for those people to come to during the day when their family members might be at work, where they could receive meals, social interaction, and some observation. So really at the heart of the PACE program and at its beginning was a keen understanding of the importance of social determinants of health. Right from the beginning, the very first services that PACE programs were offering, and this was before they were even known as PACE programs, were adult day health and services to support individuals with their nutritional needs and their socialization needs. What they quickly came to realize was that there was an array of services constructed around the needs of an individual that were going to be necessary in order to keep people out of the nursing home. And so they gradually, over time, started building out from this really person-centered approach to care some additional services that increased and strengthened their ability to keep people at home. So after initially offering adult day health, they soon added primary care and rehabilitative services in that setting as well, so people could see a physician and get assistance managing their complex chronic care needs. And then they realized that many of these people also needed assistance at home, and they started adding in-home care, and then finding ways to get people back and forth to the services that they needed at the adult day health care center, which is also where the primary care was, required transportation. So this was the initial cluster of services, and I suspect it's a cluster of services that sounds familiar to many of you on the phone, to many area agencies on aging, and really began with meeting those community needs and social determinant needs of the individual. Even at that stage with those services, the PACE organization, in order to do what it was doing, sought a capitated payment from the Medicaid program, because at that time, and this is going back over 25 years, Medicaid programs weren't paying for these kinds of services, and there was no fee-for-service way to deliver the care. And so again, I think it's instructive when we look back at the origins of PACE to recognize that from the beginning, a capitated payment to the PACE organization was a means to an end. It was a means to providing more flexible care. It was a means to providing services that at that point in time were not recognized as medically necessary services and were not recognized as Medicaid-funded services. As the program went on, as many of the original participants in the program aged further, what the program started to see that often when they were losing people to a nursing home or to a more institutional setting was when that person went to the hospital. And so they asked to add coverage for hospitalizations, specialist care, skilled nursing facilities, and assisted living in order to bring all of that into a fully integrated and comprehensive care model. And that is the model that we see in PACE today. And so even when they brought in those more Medicare-funded services, they brought those in as capitated services, again, to be able to offer care in a more flexible way. For example, with a hospitalization, to not be bound by the 3-day hospitalization post-acute requirements, but to really, given the network of services available to the PACE organization, be able to get them out of that hospital more quickly, back into the community more quickly, and have the flexibility through capitation to do all of that. So I think you can see from these origins and the array of services that PACE is really structured around the elder individual. It fully recognizes the social determinants of their health, and it's fully capable of integrating services related to those social determinants with more medical services and more acute care services. The PACE model today it serves people 55 and older, and that is consistent with its beginnings. So the 55 age cutoff is a little atypical for most Medicare or Medicaid programs, but it reflects the early days of PACE when it was founded at Onlock in that San Francisco community where they were serving people 55 and older, and that continues today. It serves people who are at their state's nursing home level of care, so every individual in a PACE organization meets the clinical criteria that the PACE has, clinical and functional criteria that the state has set for a nursing home level of care. In order to enroll in PACE, at the time of enrollment, you have to be able to live safely in the community with the support of PACE services. So there are people who will enroll in PACE who, in the absence of those PACE services, would not be able to live safely in the community. But the requirement is that as long as the support of the PACE services enables that community living in a safe way, then they are eligible to enroll. And then lastly, they have to live in a PACE service area. Every PACE organization has a defined geographic service area, and that service area is generally oriented around the time it would take to access the PACE programs, PACE Center, where those socialization, activity, nursing observation, primary care, and rehab services will be provided to that individual. Typically, a PACE participant is coming to a PACE center between 2 or 3 days of the week, though there is no requirement that they come, and we do have PACE participants who choose not to. The benefits of PACE have been demonstrated by a number of research studies over the years, and particularly with regard to quality. People who receive care from a PACE organization have been found to have fewer hospitalizations, fewer emergency room visits, and fewer unmet functional support needs. They're also found to have better and more years of life and better and more quality of life. This is done at a cost to the Medicare program that is equivalent to Medicare Advantage and fee-for-service, and generally less than the Medicaid cost. States are required to set PACE monthly payment rates at an amount that is less than what the state estimates it would have otherwise spent to provide care for a similar population. NPA, the National PACE Association, where I am, studies these PACE Medicaid rates on an annual basis, and what we found in our most recent study is that state Medicaid payments to PACE are on average 13% below what states estimate they would have otherwise spent to care for a comparable population. PACE is a program that has been growing We're currently estimating that we have about 53,000 people in PACE organizations. Those organizations are spread across 31 states, and each organization on average is operating about 2 PACE centers. So you'd find 2 of those locations of care per organization. And that actually continues to increase as PACE organizations expand their service area and need more centers to provide ready access to the centers. Though this growth has been steady, we recognize that there are many, many more people who could benefit from PACE program services than currently are. And the policy environment for expanding access to PACE seems to be particularly good right now. PACE answers many of the issues on policymakers' solutions checklists, and it looks like these are not going to come up. But we know that federal and state policymakers are looking for solutions that can fully integrate care, and that's something that PACE is able to do. We know policymakers are also looking for solutions that can integrate coverage, meaning integrate Medicare and Medicaid coverage for dually eligible individuals. And for those individuals who make up 90% of the people in PACE programs, PACE is the form of coverage or the form of health care for all of those benefits, for all of the Medicare benefits and all of the Medicaid benefits. So for Medicare and Medicaid, the PACE organization is receiving a capitated payment, or that is a per person per month amount from those 2 programs for dually eligible individuals. I said 90% are dually eligible, another 9% are Medicaid only, and for those individuals, the PACE organization is receiving a monthly capitation payment from the Medicaid program. And we have under 1% of individuals who are Medicare only. The payments that the PACE organization receives are the full payments for the cost of care. So individuals enrolled in PACE have no copays and no deductibles for the care that they receive. And that includes their Part D prescription drug coverage, which the PACE program is also required to provide to the people enrolled. So it is a fully integrated coverage model, Medicare, Medicaid, all parts of Medicare, and all covered benefits of Medicaid. And in addition to the mandatory benefits of those 2 programs, PACE programs are authorized to provide any additional benefits that the individual might need as determined by the PACE program's interdisciplinary team. And that interdisciplinary team is at the core of the PACE care model. There are 9 members on it representing all the different aspects of care. They meet daily to go over any changes in health status of a particular PACE participant, to do needs assessment, and to do care planning. As I've mentioned earlier, another thing on Policymaker Solutions Checklist is a program that can address social determinants of health, and PACE does that extremely well. And the idea of moving populations into population health management, where we can look at the needs of a group of people as a whole comprehensively, is something that has been built into PACE since its inception. The main question for PACE has been its scalability. As a program that's currently serving about 53,000 people, with the vast majority, over 90% of those, being dually eligible, we know that's falling well short of the over 2 million dually eligible people who need long-term services and supports, and the over 12 million Medicare eligible individuals who need long-term services and supports. So the big question for PACE right now is, even after its 25+ years of history and steady growth, are there ways to scale it up so that it's having a larger impact on the communities that it could serve? Oh, there they are. To try and answer that question, we've been fortunate here at the National PACE Association to work with our funding partners, the John A. Hartford Foundation, West Health, and the Commonwealth Fund, to initiate a project called PACE 2.0. And this is really looking at what is the next iteration of PACE and how can it get to serving over 200,000 people by 2028. And we look at that goal in terms of 3 different sources of growth for PACE. How can currently operating PACE programs in current communities scale up so that each of them is serving more people? How can we bring new PACE organizations to new communities so that those communities and their elders have access to the PACE program? And also, lastly, as a third source of growth, what new populations might benefit from the PACE care model, and how can we make the care model accessible and affordable for them? We include in those new populations Medicare-only individuals because even though they are technically eligible for PACE right now, if they meet the clinical eligibility criteria, the program is not financially affordable for them for a number of reasons, which I won't go into here. But we're trying to address affordability and bringing down the costs for Medicare-only individuals, particularly with regard to their purchase of the PACE organization's Part D plan, and make it more affordable. Beyond the Medicare-only individuals, we are interested in application of the care model to people who might be under the age of 55 and at a nursing home level of care, such as people with disabilities, and people who might not yet be quite at a nursing home level of care, but are clearly at risk for needing that care. And would it be possible for the PACE care model to intervene in their trajectory a little bit earlier? So this is our goal by 2028 to have PACE organizations serving 200,000 people. And the way we hope to get there is through scaling up current programs, bringing new programs to new communities, and expanding the range of people that we can serve. I'm particularly pleased with, given that goal, to be addressing this group because we hope that some of you can be a part of those growth sources. Options would be to work with a PACE organization in a current community to expand access to that program and partner with them on the delivery of services. Another option would be to develop a new PACE organization in your community if there isn't one there. With that, I'm going to turn it over to Regina, who will share with you her experience sponsoring a PACE organization in her community. Thank you.
Great, thank you, Peter, very much for this, for all the information, and it's a great segue into how and why Appalachian Agency for Senior Citizens did develop our PACE program. Oops, and I'm not very technology savvy, folks, so good afternoon or good morning, depending on, as Peter said earlier, which time zone that you live. Appalachian Agency for Senior Citizens, we are one of 25 area agencies on aging in the state of Virginia. We are very rural. Our two major industries are both coal and agriculture, so we are economically depressed at this time. But our venture truly began in 1996, as Peter was saying earlier about some of these pilot projects, and we became interested in some of the pilot projects in 1996. However, it wasn't really that we probably didn't get serious about this till about 2004 when some of the staff did actually attend some training with the National PACE Association. And then we were selected by the state Medicaid, Virginia DMAS, to participate in a rural PACE assessment instrument to determine the feasibility of rural PACE. That feasibility study was completed in 2004. And I think, if I'm not mistaken, we are only one of 3 or maybe 4 area agencies on aging that actually fully operate a PACE program. And as I said earlier, we are an economically depressed area, so some of our programs are started because of necessity. And as we all know, necessity is the mother of invention. So we have had lack of access in our community at that time to primary care physicians as well as other medical services. And in 2005, we continued our efforts all the way through 2006. We were actually awarded a grant from CMS and a state grant from state Medicaid for $250,000 for this grant implementation. We then collaborated with Palmetto PACE to develop a provider application. At that time, we did not have the experience needed, so we consulted with some experts. And then in March of 2008, we were actually granted operational status, but between that time, we also were able to build another adult day center. We already had one, which was in 1996, and then in Hayside Adult Day Center was granted an alternative care setting at that time when we were granted operational status. The other thing that was significantly different about our program is that at that time we were the only program that was granted community-based, the ability to utilize community-based physicians, and we only had part-time medical director at that time. In May of 2008, we actually enrolled our first 8 participants. We also had a mental health services grant awarded through HRSA. We no longer have an in-house staff member, but we still contract for those services. And then in 2014, we did receive a nurse practitioner waiver. We have we continue to offer these services, and in January 2020, our census was 101 participants. Our 11-year total enrollment has been 301 participants. We had at that time, and still continue to have, all the needed wraparound services, such as home delivered meals, personal care, homemaker, transportation, care transitions, housing repair, and care coordination. Through our PACE program, we have also developed other programs. We owned about 9.38 acres here at Appalachian Agency that's beside our property, our main office. It was a mobile home park. We remodeled and converted 11 of those mobile homes, converted them using universal design, and we currently do have a few PACE participants that are living in our senior community. As Peter said earlier, that people do live longer and they have a better quality of life. We have 2 of our original members from 2008, 2 from 2009, 1 from 2010. We have 4 from 2011 and 3 from 2012. And I could go on, but that would take almost all day. So I do want to go into and tell you some of the challenges that we had or that you could have if you are deciding to develop your own PACE program. The number one thing, obviously, is financial. You will not only need financial for startup, but you certainly should have enough financial means for your ongoing funding for at least 1 to 2, maybe perhaps 3 years. New program buy-in. We needed that from our staff, from our board members, and from our community. And it could be seen as this program, PACE, could be seen as a competition by our healthcare systems, our physicians. The physicians think we're taking away their patients. Nursing home facilities, or they obviously want to keep up keep their vacancy rate low, and even assisted livings, and even some of the home health programs saw us as a competitor. And so it really was an effort for us to educate the community and to have that, so that we could reduce that lack of understanding of what PACE means and what it is in the community. The other thing that we noticed is that there was a slow startup. And the reason being is that we really needed a good referral base. And so you have to have those relationships with all of those people we were talking about, the healthcare systems, the nursing home, physicians, so that you have a good referral system. And for us, we found that we needed at least 60 to 70 participants to realize a profit. So believe me, there can be some lean years. That's why I'm saying funding is very crucial to being able to start up a new program. With us being able to staff appropriately and timely, the one thing you do not want to do is you don't want to have a lot of staff around that don't have anything to do. But we also had a problem of finding individuals that were qualified, such as a physical therapist or an occupational therapist or even a master level social worker or registered dietitian, because our resources in our community are very slim, and we are all vying for the same staff through the health systems and the home health programs and everything. So our resources, even human resources are limited as well. We also have a problem with our geography and terrain. As Peter said, you do want the individuals to be able to come to the medical center or to attend the adult day center or attend an alternative care setting. So We do have an issue with a lot of our individuals that do not come into our adult day centers, and we do provide their services in their homes. And sometimes we can travel as far as 2 to 3 hours to visit a participant. We do have a lack of specialists in our community. So there is an additional expense for travel outside of our community to our specialists. And scheduling those visits to the specialist, so we even developed our own in-house transportation program as well. The other things is sometimes our PCPs and specialists weren't willing to sign contracts for our services. They didn't have an understanding. They were afraid of how they were going to get paid or when they were going to get paid, and some of them didn't understand that we were both the provider and the payer. So it took a while to get their buy-in for that. And then meeting eligibility, the Medicaid requirements, and passing screening requirements. We have 4 local departments of social services, and all of them do have autonomy, but sometimes we wonder about their translation of the requirements and their definition of 24-hour service. We have some issues with that as well. Now, this is a disclaimer because these are mine or the agency's perspective on the community impact. Some people may say that it's less or they may have more of a negative, but I feel that this community impact for us and for our community has been that we've created new jobs, we've had a positive financial impact on our community, as well as our agency. And as I said earlier, we have had some lean years, but it has had a very positive impact on our agency, and we're able to provide services that in the past we would have never been able to have provided. Families get to keep their loved ones in their home, which is where everybody wants to be. They all want to age well, and they want to age in their home. We also, by being able to have these individuals, by providing personal care or homemakers or the attendants in the adult daycare, these individuals, their caregivers, are able to be employed. We even had one lady, one family, the daughter said, I was able to get married and have a life because of your program, which gives you very good heart feelings for that. We do provide educational programs to our community through our All Care. We provide colleges, universities, opportunity for experiential training and learning. We have better quality health outcomes. Our A1C rates are lower than the national average. Our hypertension rates are better than the national average. And we actually have, we think, a greater participation in immunization, individuals agreeing to take that flu shot and the pneumonia shots and other immunizations as well. It is a lower cost to the Medicare and Medicaid programs because it is a capitated rate program. Those are cost-shared savings programs with Medicare and Medicaid. We feel that we also reduce costs by having less ER visits, and we do have a reduction in hospital readmissions. And we also feel that it reduces the drain or the need on community resources. We actually free up community resources to be used elsewhere within our community. And you ask, well, how can we partner with the PACE? Well, you can partner with the PACE, find out if there is actually one within your community, within your locality or region. You also need to ask yourself, how would partnering with PACE support your mission? Would it support your mission or not? If you can answer yes to some of those, then that might be set those columns yes or no, and which one has a greater impact. Ask the PACE program, what services do you need? What do we have as an organization, as an area agency on aging or a tribal or community-based organization? What do we have that we can help to support their mission by keeping that individual healthy and in their home? Services available for private pay. You're going to sell your services. Do you have adult daycare? Do you have homemaker, personal care, nutrition, care transitions, care coordination, or counseling, transportation? These are all services you can sell that are fee-for-service or private pay. Be sure that when you partner with PACE that you set your pricing and market and sell your programs. You don't ever want to you have to know you are the experts. You have to know what your programs cost, what your staff costs, and do not be afraid to negotiate. That's one of the things that I have seen in the past is that area agencies on aging, being a social service, how do we turn our social service programs into business models? And one of the things is to please learn the art of negotiation. So if you decide you want to develop a PACE program, I certainly recommend that you start discussions with your state Medicaid. Those are going to be, and you may even want to reach out to the National PACE Association and ask how many, if there's some in your service area, or if not, and who your local Medicaid staff will be that you need to contact, because they will have all that information for you. So reach out to them and start that discussion. Say, this is something we may be interested in if we are going to develop our own PACE program if there's none in your community. You obviously will need to do a feasibility study. You want to make sure that it does meet the mission of your organization, compare any programs that might be in the community, make sure that you've done your research if you need to do a community service needs assessment, or if there's, and look for your foundations and see if there's any availability of grant monies that might be there at your beck and call if you need them. So we perform an elder community, we do an elder needs assessment every year, but we also partner with our community and our hospital systems to partner with them on community needs assessments as well. So we not only know what's needed with our senior population, but also what's needed within our community as well. You definitely will need to work with your state Medicaid in regards to an RFA, which is a request for application. They will want to know if you've determined your readiness of your organization. Do you have the infrastructure? Do you have, say, land? Do you have availability, location, or are you able to develop something within your community, or is someone willing to give you property if you don't have an adult day center or a medical clinic? Have those meetings early on with potential partners. That's going to be your home health agencies. It's going to be your Department of Social Services. It's going to be even your local businesses. We've gone directly to our county administrators and to our Board of Supervisors, as well as to home health and assisted living, and with our nursing home institutions as well. Make sure that you have funding, as I said earlier, startup and operational, because things can be lean, and you do not ever want to leave yourself without that cushion of funding in case there's something happens, there's a take back or look back on some of the other programs that you might be doing. Make sure that you have a location, you're ready to develop that, or it may already be developed. What services, do you have the availability of the core services within your own organization? If not, who are you going to have to partner with to have those core services, such as medical and the adult daycare and some of the in-home services, as well as transportation? So can you recruit timely for all of these services, or can you recruit timely for your staffing development? Do you have a medical director? Do you have access to good nurses or nursing? Obviously, PT and OT. We had issues with that and contracted that out for several years. Adult daycare, do you have that in-house, or are you going to have to contract for those services? In-home care, social workers. Can't say enough about having your master level social workers, your registered dietitian, and we also have on board a clinical pharmacist as well. And then, of course, you're going to, if all of these things fall in place, all these blocks fall in place, then you are also going to want to, if the state puts out an RFA in your community, then obviously you will develop that application, and then you will complete that, and then that will then be accepted or not accepted by your state, and then those also go to CMS for approval. And it certainly does not hurt that if this is the first time you've had the opportunity to do this, to reach out and hire a consultant. Hire somebody that has experience and has had success either partnering or developing a PACE program. I call this PACE in action. This is Mr. Don. He was Mr. Hallmark. When I met his nephew in 2010, when I started working here at Appalachian Agency, his nephew told me, he said, my uncle would not have been in this program 6 months if you all had not come along. He had actually been, he was, did attend adult daycare, so he learned very quickly about the PACE program. He was in our program from 2008. He was one of our original until July of 2019. He was the epitome of PACE living successful. He never missed a day except for the last 2 days of his life that was not pre-scheduled for the Adult Day Center. He loved the children. He was quite the flirt. But more importantly, he had the wonderful support system, those caregivers that we have found with us that we do not have. Sometimes that support system is very dysfunctional. So we are taking, as Peter says, not only the social determinants of that individual, but sometimes we also are the social workers and the social determinants of that entire family. So be prepared to handle those kind of situations as well. But Don was truly, he could be the poster child for PACE. He lived a great life. We helped him to remain active. He was quite the flirt. He loved to dance, loved beach music. If you can take Don, and he was also prom king last year, so if that tells you anything, how much everybody loved him. So those are the types of things that the PACE program does that you can't put in a textbook or you can't put into a medical record. Anyway, thank you all very much. I certainly appreciate the opportunity to speak with you today, and I'm sure that our information will be there, mine and Peter, so that you all can ask questions. And I think we've left plenty of time now for questions to come through.
Oh, you're killing me.
Peter, I have had a question before that individuals ask about a conflict of interest because we are the PACE program, the All Care program, but then we also provide homemaker, personal care, transportation, and we do this through contracts within the agency that are approved through the state, Medicaid, and through CMS. So in case that was a burning question for anybody, that's how we prevent conflict of interest.
Yeah. Thank you, Regina.
Okay, thank you.
Yeah, go ahead.
Yes, go ahead, Peter.
No, I was just going to ask actually you if there were questions from the coming in on the webinar that we might want to address.
Indeed. We will get to those questions right here. Peter and Regina, thank you for a great presentation. Everyone, it is time for the Q&A period, so send in those questions right now. And presenters, let's just jump right into it here. First question here, who do you consider to be the people that could benefit from PACE that are not currently?
Regina, I'll take a general shot at that, and then I think folks might be interested from your perspective about, who you see in your community that might be expressing interest in the program and who aren't eligible to enroll. So currently enrollment is limited to people 55 and older at a nursing home level of care. And so one of the populations that we think could benefit from PACE is younger people under the age of 55 with physical disabilities. We also think people with early onset Alzheimer's or dementia might benefit from the program, particularly when that dementia is combined with multiple chronic illnesses, so you see that combination of medical and functional support needs that is really what the program is designed to address and integrate the care for. We were able a couple of years back to work with Congress and pass something called the PACE Innovation Act, which authorized the Center for Medicare and Medicaid Services to have PACE pilots for these new populations, and we continue to be hopeful that they'll move forward with those. There was some activity a year or so ago looking at serving people with mobility deficits through a PACE pilot, but that activity has not yet resulted in an opportunity to apply to participate in a pilot. But I see those populations of people who are not currently able to enroll as possibly benefiting from the program. And as I mentioned, for affordability reasons, I think there are some great opportunities to serve more Medicare-only individuals who are 55 and older and are at a nursing home level of care if we can address the cost that they currently pay to purchase a Part D prescription drug plan from a PACE organization and the lack of flexibility that PACE organizations have in setting the amount of the private pay monthly premium or capitation that the individual Medicare beneficiary has to pay. So that's how we've been looking at it generally from a policy perspective. Regina, I'm curious, in your community, do you see folks coming to your door that you're not able to enroll, and who are they?
Yes, thank you, Peter. We do. We see a lot of individuals, as I call them, pre-nursing home eligibility. They're individuals that they've had a decline or they've had a sudden decline, or as you said, mobility issues or dementia, and they are, I say that what are they going to be like in 3 months? What are they going to be like in 1 month, 3 months, 6 months? And in that 1 month, 3 months, 6 months, if they're in the PACE program, how much more we can do for them and for the family as well, and increase the quality of their life and even medically make a lot of different changes as well for them. But we also do have the issues with eligibility, screening, and getting those individuals within our community. And as sometimes I've said that they are not just pre-nursing home, they are, sometimes when we get them, they're pre-funeral. So we really need them a little sooner than we're helping the families to do those pre-needs for the funeral. So there's that potential there to get the group that you were talking about, but even some of those individuals that are there's just some little things that they still, that they are starting to decline, and you see that, and you know that in 3 to 6 months that they are not going to be able to manage themselves much longer.
Okay, thank you. Regina, this question is for you. What percentage of seniors in the area are served by PACE programs?
In our community, we only probably have about 1% that are eligible that are in our program. We have probably close to about 2,300 that are, or between 2,300 to 2,500 that are eligible. And as you know, we have 101, so almost really less than 1% of those, or less than 10% of those individuals are in our program. So we would love to have, 10, 15, 20% of those individuals in our program. But again, it's scalability, as Peter was saying there as well, because we've had in the past that CMS may say, well, you signed up for 125, this is all we're going to give you, but you've got to relax those numbers for us as well, depending on our ability to serve those individuals safely.
All right, thank you. Next question. Is PACE quality assurance monitored by a particular oversight panel, or is it specific state by state?
Peter, actually both. It is monitored by our state. We have that we monitor in-house, but it is monitored by state, but it's also monitored by CMS.
Okay. Peter, this next question's for you. Why are you projecting so little growth in new PACE programs?
Steve, I'm unfortunately in a building with a fire alarm going off. So I don't know if you all can hear me, but I'll just say we consider the 200,000 growth to be pretty ambitious based on current growth rates. And we recognize that PACE isn't going to be the right solution for all 2 million people. There are other options that they'll have. But we would like to be present in all communities to be an accessible option for all communities. And I'm going to put my phone on mute and hope that the fire alarm stops.
Okay. Well, if there is an actual emergency, Peter, we do encourage you to head on out if you need to. Next question. How do you explain the benefit of the PACE models for people who are reluctant about having new service providers?
We did have this problem when individuals first came into our program. Fortunately for us, we were able to have community-based physicians, but of course not every PACE participant had, access to the same community-based physicians that we had on staff or had a contract with. We did allow those individuals, we do allow those individuals to continue a relationship with their medical providers. However, we have noticed that within a month to 2 months of being in this program, they number one, love the nurse practitioner or the medical director, and they see the ease, they see the efficiencies, the access that they have on a daily basis, which they are not getting in that, what I call the fee-for-service provider world. You see your provider every 3 months, or you may be able to go and see them, if you have an acute illness or something like that. But the accessibility to our medical providers here, it really is it can't be beat. So a lot of the individuals really do switch over and decide to take our medical director as their provider.
Okay, thank you. So what sort of background or education should an individual have if starting a PACE program?
I certainly encourage healthcare. If they have, if they've worked in healthcare programs, obviously nursing, if they've been a physician, of course can do that, or anyone, healthcare administrator. So it really does help, but it also helps to be able to have a business background. And within our agency, we do have the infrastructure because we had human resources. We have information technology on board. We have a robust accounting department on board, as well as the other departments that you have. So if you're going to start from the ground up, you're going to have to put those team members together as well as knowing the medical piece of this to go out after to develop a program.
Yeah, and this is Peter. I just want to. I'm safely out of the building. The fire alarm is over. But I'll just add. I think the other aspect of operating a PACE organization is while you are a direct care provider, and many of the services you'll provide directly, such as transportation and even primary care, where you'll be hiring your own physicians or nurse practitioners. You are also acting as a payer to pay for the services that the individual might need in a hospital or from a specialist. And you're also capitated, so you're getting that flat monthly rate. You're not going to get paid a fee-for-service rate. And because of all of those aspects, there is an element to PACE where you are a plan as well as a provider. You are a health plan as well as a provider. And I think this goes to the sort of business acumen that Regina was mentioning. It's important to have those business skills in place around network management, claims management, all of that. Regina, I'm sure it's not the most favorite part of your job, but it's a big part of the job.
Yes, Peter, I agree with you, and my apologies, I kind of left that piece out, that you do need someone that has medical billing experience, a professional coder, a certified professional coder, because they need to be able to understand when payment comes in, those risk adjustment payment scores and things that are related to the capitated payment, and the frailty factors and just coding. So having that good medical background, medical coding and medical billing background is very helpful, which helps if you have those business people that have worked in not just a business, but in medical business, such as in a physician practice or in healthcare that has experience in medical records or medical billing.
Okay. Well, kudos to you, Peter. You're a true example of the show must go on. So Thank you for staying with us. Next question here. What does the ongoing PACE funding model look like?
Peter, you probably know that answer better than I do.
I think that, and again, I'm in a lobby. Everybody's filing back into the building, so I apologize for the background noise. I mean, the ongoing funding for PACE looks good. We are a permanent part of the Medicare program, so we're no longer, we started out as a pilot, but we are now a permanent part of the Medicare program. And that funding has been steady for us over the last few years. Our funding model is based very much on the Medicare Advantage program funding rates. But we've seen steady, if small, increases in those Medicare payment rates over the last few years. And each state sets its own Medicaid rates. So we do see a kind of range of experience there. You know, in any given year, some states might be lowering rates while others are increasing them. But on average, they've been holding pretty steady. And PACE programs have been remarkably and consistently financially sustainable. Once you get past the lean years.
Yes, and I will say that Virginia is a very PACE-friendly state. So it is, as Peter was saying, it is state dependent and state dependent on their costs. And we're hoping that if you do not have, there's 31 states, there's 19 states that have the potential, and I'm going to use West Virginia as one of them because we are within 30 minutes of West Virginia, where our office is located, or about 45 minutes from where our office is located, that we have a lot of people from West Virginia who have called and want to be in our program, but because they're in West Virginia and it is a Medicare Medicaid program, we can't accept them. So if when West Virginia did not opt in when we were doing these pilot projects, but we're hoping that these other 19 states will see that this is truly a program that is very beneficial to their constituents in their states.
Okay. Regina, this next question is for you. Can you talk a little bit more about the services that you can offer as a result of partnering with PACE as compared to not having such a partnership?
Oh, for individuals that want to partner, well, with us, we fortunately are full service. But if you do not have, if you are going to partner with the PACE, you need to look and see what you have in, what core services are you offering. Are you offering nutrition, Meals on Wheels? You may contract your Meals on Wheels program out to that individual. You may contract out, if you do in-home, we have a direct waiver in Virginia, so we are able to do in-home and personal care through our area agency on aging. Some are not, but you might be able to work with them to help subcontract these other individuals, individual programs. You may also have transportation within your agency, so you would be able, your CBO, so you may be able to offer transportation. So you need to look what programs you have. Do you have care transitions? A lot of PACE programs may not have that care transitions intervention program, and you could offer that to them to help reduce their readmissions. We've done that in-house as well because we do have all their staff in care coordination have been trained in the Coleman model, so we do care transitions intervention, and we have a contract between care coordination and PACE, our all-care program, that we provide care transitions intervention with that individual, so that not only are they getting the things from PACE that need medical and social and everything, but then we also have a whole other community and our care coordinators who are also going out and assisting the PACE program, because a lot of times you may look at this individual through different lens than what they're looking at it from the PACE side. But a care coordinator or a social worker may look at that differently than what they are in PACE. So you have plenty of opportunity to offer those kinds of programs to a PACE program.
And I just add to that, I think we mentioned in an earlier slide that if you're interested in more information on PACE, N4A at its spring policy event coming up on March 17th is offering a PACE pre-conference, and we're going to have 3 different kinds of case studies related to PACE and area agencies on aging. One will be a program like Regina's, where I think actually, Regina, you're reprising your role, where it's the development of a PACE organization by a AAA. Another will be an example of a AAA that partnered with another organization in the community to sponsor PACE. And the third will be a case study of a AAA that is providing services under a contracted arrangement with the PACE organization. I believe that AAA is providing transportation services, but the director was previously at a different AAA where he was providing care management and home care to a PACE organization under contract.
Okay, thank you. I've got several questions here that are kind of under the same umbrella, so I'm just going to combine them all into one. Do you have any efforts, or what is being done, if anything, to try to move PACE into any of the 19 states that are currently without it?
Yes, we do. We frequently reach out to states to talk to them about PACE and adding it. What we found in the past is where we've been successful bringing PACE to a new state is when we do that in the context of a provider that is interested in developing a program, because it really takes the conversation out of a hypothetical where we're talking to the state about sort of hypothetically adding a new program. If we have an organization that is there and sees the need in the community and wants to develop the program, the state is much more likely to engage with us. We are looking forward to the District of Columbia, which is not a state, but close to it, coming on board here soon. They're getting ready to release a request for applications to have a PACE program here. We don't have one. And we've been in conversations with a number of other states. As Regina mentioned, at the National PACE Association, if you're interested in talking to your state, if there's any way we can help you, please feel free to reach out to us. We're happy to do that.
And from our perspective as a PACE program, I have met with a couple of legislators, senators, and both state and federal from West Virginia, because they are so close, and sometimes some of our programs will cross over with each other, so those legislators will be there. And so again, I always talk about the PACE program, and I have encouraged them that if they would like to do a pilot project in one of the county that border, the 2 counties that border us the closest, that we would be willing to do that with them. And it's been to no avail yet, but you just have to keep asking, as Peter says, and keep those conversations going with them to potentially say this is needed in our community. And it also has to come from the constituents. If we have people calling us, I tell them, call your legislators, call your delegates, call your congressman, call your senator, call your governor, whatever you need to do. So there's multiple fronts at which you can direct your efforts.
Okay. Well, Peter and Regina, unfortunately we are out of time here. We've reached the end of our hour. But I want to thank you for a great presentation and for joining us today. Thank you so much.
Thank you.
Thank you.